Hello, hello, hello. Dr. Amy Killen here, and we are going to be doing an Instagram live with Dr. Douglas Lucas, who is an orthopedic surgeon, and he's also an osteoporosis expert. So I'm very excited. Hello to all of you who are starting to join. I am here at home. We'll give people a little bit of time and talking about osteoporosis because of the connection between hormones and women developing osteoporosis, which we know is now unfortunately very common. About 50% of women over the age of 60 will develop an osteoporotic fracture, which is crazy. And of course, if you follow me for very long, you understand that my mom had a fracture, a broken hip about a year ago, which was kind of the reason you guys are getting on. Hello to everyone. I think I just invited Dr. Lucas. Oh, here we go. He's coming. He's coming, I think. I'm going to let my dog in because he is barking at the door. I left him outside for too long. But anyway, happy to have you guys here. Hi, dog. My little dog, who I think is still outside, he likes to run away and go into the woods. And then he likes to hunker down and just sit there and wait for me to come rescue him because he is a very bad dog. Okay, let's see here. Why is this not working? Yes, I said yes. Yes, yes. Dr. Lucas, I'm trying to get you in. I don't know why it's not accepting you. Otherwise, these people want to hear me talk about osteoporosis for a long time, which is not as fun as having another person. I don't know what's going on. I'm always so bad at these. I feel like every time I can't get people in properly. But I have tried to, I've accepted you, Dr. Lucas, multiple. Oh, there he is.
We made it.
Oh my gosh, why was that so difficult all the time?
I don't know.
Oh, my little dog really is trapped outside somewhere. He's probably run away, but we're just going to leave him. Yay. Okay. So this is, so people who don't know, this is Dr. Doug Lucas, and we met kind of virtually a month or so ago and have a similar passion for improving bone health in midlife and beyond women. So I'm super excited to have you here. I have some questions for you, and then maybe we'll just kind of start off and just chat, but tell us a little bit about you first so that people know who you are.
Yeah, so just like you said, we have a similar passion for bone health and hormone health. And what I love about your content and what drew me to reach out to you was that the way that you dissect studies and educate people about, what the literature is actually showing versus what the recommendations that most people are seeing. We're doing the same thing. We're just doing it in a different audience. So I wanted to connect that way. My background is in orthopedics, so different background than you. Orthopedic surgeons generally don't actually know much about bone health, surprisingly, nor about hormone health. So I left that about 5 years ago now, went through a functional medicine pathway, created an integrative practice, and then sort of landed in the bone health space. Absolutely loved all the controversies within it, realized that women especially, but both women and men, weren't getting the treatment that they needed. So I created a YouTube channel to sort of shout that to the world, and the world is kind of listening. So it's been a snowball from there.
And do you have a practice still also, or is mostly virtual that you're seeing people?
So I started the practice in 2020. So I leapfrogged the telehealth changes, and we started telehealth, and we never changed because we have patients all over the country. So I don't have a brick and mortar. There's tons of things I would love to do in a brick and mortar, but I don't have the capital, and I don't have really a need. So right now we just stay telehealth.
Well, that's awesome. So for any of you listening who are, need help with, you have osteoporosis, or you're concerned about it, or you have risk factors for it, or you don't know what to do, Dr. Lucas has a lot of different programs that I've seen that are online, and then also does telehealth all over the country. So that's an amazing resource. I think people have a hard time finding doctors. Yeah. So let's dig in to some of the questions that I get most frequently. So one of the questions I get a lot is, what are the supplements that are most associated with bone health? Can you share the ones that are, and then maybe share the ones that people think are associated with bone health, but really don't do that much good?
Yeah, and just to clarify, you're talking about the ones that people are using to improve their bone health.
Correct. Yeah, to improve bone health. Yeah.
Yeah. So it's funny. I kind of joke about this, and maybe it's not that funny, but people with osteoporosis and osteopenia, or low bone density, as it should be called, are generally a group of people that don't want to use pharmaceutical drugs, but they really want to use supplements, which I think is kind of a funny contrast. But what I say about supplements is this: nobody's going to supplement their way out of osteoporosis. It's not a supplement deficiency problem. We use them, they're valuable, but we focus on the lifestyle things first. Maybe I'll answer this backwards to say that where I see people focusing, and this is not their fault, this is what their doctor tells them to do, but I see people focusing so much on calcium and vitamin D. Now, vitamin D part is important because especially if you're vitamin D deficient, truly deficient, like less than 30, or definitely if you're less than 20, we need more vitamin D. I prefer people to get it from natural sources if they can. Most people can't, so we supplement. But the calcium part is really interesting. If you look at the recommendations across the globe, we really don't need more than 700 or 800 milligrams of calcium in order to maintain bone. That doesn't necessarily mean grow bone, but maintain bone. And that's pretty easy to do through diet, even if you don't consume dairy. So we really don't need to pound calcium supplements, but we do need to give our bones everything that they need to build. So we recommend, instead of calcium specifically, we say, let's get whole food forms of calcium, which could also come in supplementation, but let's consider it like a complete mineral complex. So we're getting all of the minerals and not just the calcium, because your bones are made up of more than just calcium. So I'd say the calcium focus is kind of the biggest error that I see. And then I find people they go crazy on supplements. We have people coming into our program that are taking 20, 30, 40 supplements a day. And it just is absolute overwhelm. And they usually have gut dysfunction anyway. So they're probably not absorbing any of it. They're just spending a ton of money. And so what I like to do is usually we narrow this down. We found some foundational things like magnesium, potentially B vitamins, depending on labs, omega-3s for potentially inflammation and oxidative stress, if that's a thing based off of labs. And then we get bone health specific with like some, a complete mineral complex, some fat soluble vitamins. And then there's some bone health, like kind of unique things that would be like lactoferrin is an interesting one, or like French maritime pine bark extract. These things have been shown to improve bone density on their own. And then we get into the health span stuff, which then gets to a very extensive list, but it doesn't need to be that big. And we've really, over the last 4 years, we've been narrowing our supplement list.
So I heard vitamin D, magnesium. I didn't hear vitamin K or K2. I assume that that's
I mentioned,
part of that, or no?
yeah, the fat soluble vitamins are D, A, E, and K all together. Yeah. And so we
Yeah.
definitely, you need, if you're going to take D and just, well, back up. If you're going to take calcium, you need to take D. And if you're going to take D, you should take K. And then you also need A and E.
Okay. Yeah. That's the ADEK. ADEK is how we learn those fat soluble vitamins. So that's good. I love all of those things, and I think that it is important to go way beyond supplements. You and I have also corresponded about the importance of estrogen, and one of the questions that I get, I mean, everyone knows that estrogen is good for your bones and preventing osteoporosis. Like even traditional doctors now recognize that estrogen therapy will help prevent bone loss. And I think it's even FDA approved for that. But there's still some discussion about whether estrogen therapy will help reverse osteoporosis or osteopenia once you have it. And I know that right now, bisphosphonates are still kind of considered first-line therapy for reversal, which we could talk about. But tell me your thoughts on kind of people who already have bone loss. Maybe they're even more than 10 years out from menopause onset. They're kind of late starters. They missed the boat because of the WHI. What do you think about those women taking estrogen?
Yeah. And this is Mike. I don't know what percentage, but it's a large percentage of our practice are women
Yeah.
who were mismanaged in the early 2000s, and now they're 65, they have osteoporosis and regret that they didn't consider HRT. So absolutely, this population, we need to have this conversation. So how powerful is it? Well, we collect data, not well. We kind of collect data in our practice, the best of our extent from a clinical perspective. And I reported on this recently, but one of the things that stood out more than anything else is when we looked at users of HRT, even if they weren't at goal, but just any HRT versus non, just stark contrast regardless of age. So the impact is going to be there for your bones regardless of age. So if you're a 90-year-old woman and you want to start, I wouldn't necessarily recommend this, but just as an extreme example, a 90-year-old woman 40 years out from menopause would likely still see benefit from estrogen. Now, again, I'm not telling any 90-year-olds to go start HRT. but just as an extreme example, because the receptors are still going to be there. And once you expose your body to the hormone, they'll upregulate, your bone will start making more of them, and it'll be all over your body. So we see, yeah, regardless of age, tremendous impact. And if you look at the literature, one of the cool things about bone health, if you look at hormones through the lens of bone health, is that all the bone health literature really says a lot about HRT and potentially the most effective ways to dose it, strategies, timing, dosing regimens. And if you look at what's most impactful, you can see studies up to 10% improvement in 12 months in bone mineral density. That outperforms any of the pharmacologic drugs. So yeah, it's
Yeah,
super powerful.
it's crazy. And bone is interesting in that it is very sensitive to estrogen, even low doses. Like, and I've done
Mhm.
posts on this before, but you could even like micro doses of estrogen can at least stop bone loss. So you don't have to. I mean, I am a fan of HRT. I'm a fan of getting your estradiol in your serum up above 65 or so, because I think that is beneficial for not just bones but heart and brain and all that. But even if you just have an estradiol of your serum of 30 to 50, you can still see that you're stopping bone loss. So, if
Yeah.
you're not tolerant to estrogen, even low doses help. And then unlike some other organ systems like your cardiovascular system, we can see, like you just said, we can actually start hormones late and still see benefit. And that's a little different than some of the other systems. But the
Right.
bones just they
I
love
love
estrogen. They're all
it.
about
Yeah,
it.
they love it. Well, they love all three of them too. They love
Yeah.
progesterone and they love testosterone. They're just not as well studied. And so we can't say to what extent they love them. But estrogen for me is so crystal clear. And I'll add one more clinical pearl to that, which is that we find that for some women, you're right, low, measurable, but low levels of estradiol and serum, we're seeing tremendous impact in their bone turnover markers, which is awesome. But for some women, we don't see it because we used to do kind of the same thing, like 60 to 80 was sort of our arbitrary threshold for estradiol and serum. What we found is that once we started measuring FSH and looking at bone turnover markers, we found that even at that level, some women still didn't see an impact. So we would drive them higher, as high as we could with if we're staying on a static dosing schedule. And then once we saw FSH drop, we would see their CTX, the bone turnover marker, drop. So I do think there's quite a bit of variability where some women will see benefit with low dose, other women need higher dose, and you really have to look at the biomarkers to understand what's happening.
Yeah, so it really is like a linear relationship between dosing. I mean, I'm sure at some point, obviously, the dose it just plateaus. I'm assuming,
Yeah,
but
you will
higher
saturate, yes.
doses do lead to better bone formation up to a point. Do you know what that? And I've looked into this, but I don't know what the point is, what that max is in terms of like when do you kind of saturate receptors and plateau like
Yeah,
the estrogen level?
I think it's going to be variable. Definitely, the study has not been done that would show this definitively because it would need to be a big study across multiple age groups. It would be hard to do. But there are some studies looking at dosing, but they don't measure very logically or report it that way. So we don't really know. There's one study I saw, and it was relatively small, but they were actually almost creating like a rhythmic pattern that was sort of like physiologic restoration, if you've heard of that. And this was old though. This was like 25 years old. This was like before PR was really a thing. But they measured though on day, I think it was like day like 18 or something. So like we didn't catch either side of luteal or follicular. So we don't really know what was going on in that study. But my guess is it's probably going to be the upper end of that follicular range, right? So it's going to be pretty high to
Mhm.
saturate it. But I don't think we necessarily need to get there and certainly not stay there because that would be hard to control. So
Yeah.
I think there's a lot of learning to do.
Yeah. So speaking of that, one thing I've heard you speak or at least mention, and I get a lot of questions on this, so I'd love your opinion, is if you have opinions on cycling of either estrogen or progesterone. Mostly people talk about cycling progesterone,
Yeah.
and because if you have a uterus, you still have to take progesterone at least 12 days in a row, consecutive days in a row to protect your
Right.
uterus. And there's a lot of discussion, among hormone doctors whether or not we should be cycling that or not. There's potentially pros and cons. I haven't seen a lot of literature. I've seen some animal studies on it, but I haven't seen much in humans that have compared,
Yeah.
cycling versus not. But I would love your opinion about that in bones.
So I'll send you a summary slide that I have from one of the talks that I do. There's a meta-analysis from I forget how long ago, but they pulled all topical estradiol studies that met their criteria. And I think there were something like 12 or 14 studies in there. And some of them, about half of them, were using some kind of a rhythmic protocol and half were using static. So you can't necessarily compare in each study, but you can compare like the studies that used it rhythmic versus not. Every single rhythmic study outperformed the static one.
Mm.
Every single one. So it's pretty compelling to say that probably rhythmic makes more sense. And I kind of look at it like this, like, I mean, clinically, we don't, this is such a weird thing we do with women, and I don't understand it, but why would we take hormones that naturally cycle and then after you go through menopause only use static? I
Right.
mean, I understand clinically why, because it's easier, there's less side effects, it appears to be
Right.
safe. Like I get all the reasons why, but if we truly wanted to maximize what the hormones are doing, it would make sense to cycle them. But that gets you into the physiologic restoration world, which then we're asking postmenopausal women to go back and have a monthly bleed. And like that's a tall ask, at least in my clinic. Like I don't have that conversation very well. But I do think that there's it's just not easy for me to do. But I do think that there is a range where we can take women who are on static and potentially not seeing the benefits they want to see. And there's a whole range between that and true PR where you're actually cycling and provoking
Yeah.
menstruation. In between, there's cycling progesterone and keeping static estradiol, which if you do well, I think we can get the benefit of the cycling of progesterone, a little bit of that push-pull, and then we just want to make sure that we're covering the uterus if a woman still has one. And we recommend that our patients get an annual transvaginal ultrasound to make sure, because we are driving estradiol levels up. We just want to make sure that, even if they're not having breakthrough bleeding, that we're not building that up unnecessarily.
That's a good point. And yeah, the progesterone dose you take, it should be proportional to the estrogen dose. And people, I get a lot of questions about this, and it's difficult because there's so many different forms of estrogen, so many different doses, different compounded versions are not as well studied. And so there's all this, it's hard to say
It's hard.
like, what's a low dose versus a high dose. I mean, I can tell you what a low dose is, but the medium, the high, it varies very much depending on what kind of estrogen you're taking, the route, et cetera. But in general, that is true that you want to have, essentially, if you have higher estrogen, you want to have higher progesterone to protect that.
Yeah.
Right. I have another question for you that I've been getting a lot, and
Yeah.
I suspect you have gotten it as well. I would love to talk about the
Mm.
GLP-1s and bones. And
Yeah.
there's concern, and I've heard concern about there's some viral Instagram videos about people who have become osteoporotic on GLP-1s, but I've also read some literature that it looks like the GLP-1s are actually bone positive
Yeah.
and they actually can be great for bones. So let's talk about those. And
Yeah.
it's interesting.
I recorded a video on this. I don't think it's out yet, but I wanted to record on this because clinically we have patients that'll come in. Now, most of our patients are underweight, so we don't have a lot of overweight patients, which is kind of a unique practice. But of those that come in that are overweight, that are working on either maintaining or actively losing weight, some of them are on GLP-1s. And so early on, we were like, well, the literature actually supports it. Because you're right. If you look at like the longevity literature, the microdosing conversation, the GLP-1 mechanism, because it improves insulin sensitivity, it may actually be beneficial for bones. So we early on said, look, you can stay on your GLP-1s, just promise me you'll track your protein and you're going to be doing resistance training anyway, so we should be okay. But what I can tell you is that clinically, every single one of those patients lost bone in their repeat scan.
Really?
Every single one. Now, this isn't a huge number, but I can think of at least 6, maybe 10 patients, and they're in our program, right? They're doing all the things and they're still losing bone on repeat scan. So it's concerning to me that, we have now how many millions of people that are taking these drugs. I was actually talking to a friend of mine who's the CEO of a big telehealth company. They have, I think he said 250,000 people on GLP-1s. And I said, how many of those do you think have osteoporosis?
Uh, So
Right?
and even at the micro doses, and a micro dose just is, there's no, that doesn't
Don't
really,
know
it
what
just
that
means,
means. Yeah.
right? Yeah, we don't really know what that means. But even at the lower doses, are you seeing that at those low doses too?
All of the patients that we followed initially, they were all taking the true pharmacologic doses. So they dosed it according to how they were supposed to. And that's how we initially dosed it, because I do prescribe it occasionally, not much. And that's how we dosed it too. Now, if you're my patient and you want to be on, I would only use tirzepatide if we can get it. but I would use it at what I consider microdosing is like a half of the initial dose or maybe a half of that.
Yeah.
And I know people do less than that. I think at those very low doses, you are probably going to be able to get adequate protein in. I've used the drugs myself, and I can tell you that if I take even the starting dose of tirzepatide, which is Mounjaro, for those that know the brand names, even at that dose, I cannot eat adequate
Yeah.
protein. And for me, that's like 150 to 180 grams a day. I can't get there. I just physically can't do it. So I know that my patients who already can't consume adequate protein because of gut dysfunctions, part of why they're there, if they go on a GLP-1, they're not going to consume any dietary fat or protein at all.
Yeah.
Not because they're doing it intentionally. They just physically can't do it. So yeah, I think it's a problem.
What do you like for protein in terms of grams per day, every day? Like, what's your metric for advising patients on protein?
Yes. So we have this kind of round number starting point of 1 gram per pound, which is 1 gram per pound of ideal body weight. I should say
Yeah.
it that way. We use that because it's easy to remember. It's a reasonable starting point, and most of our patients are so far from there that that's a reasonable goal.
Yeah.
We adjust that over time. Not everybody needs that much, but if you have gut dysfunction, you can't break down protein, you're probably going to have to overshoot it. If you're getting most of your protein from plants, you're going to have to overshoot it by a lot. So we start with that 1 gram per pound, ideally of animal protein, if you can do that, and then adjust it from there. But we find that once people start to hit that point, then everything else in the diet kind of falls into place. So that's sort of become like, this is our starting point of all of the dietary recommendations is let's hit your protein and then we can figure everything else out.
Yeah, I like to say the same. I like to do 1 gram per pound of ideal body weight per day, and then at 25 to 30 grams of fiber. And I feel like if you do those two things, then it's really the rest of it kind of falls into place because you're not hungry, you don't really crave as much else. If you just focus on those two things, that goes a long way. All right, let's switch gears because something else that I've talked that we've discussed on the computer are some of the testing that we can do to look at bone health. And I think that a lot of people are under the misconception that the only test that is out there is the DEXA scan, which, by the way, the recommendations from the U.S. Task Force Preventative Services people is ridiculous, which is that you wait till 65 to get a DEXA scan unless you're high risk, which is crazy talk. So DEXA scan much earlier, I think. But tell me about some of the other tests that you're doing to look at real-time bone absorption and bone building.
Yeah, so I just want to hit on that same point about DEXA and waiting until 65. I mean, I understand from a public health perspective, right? Like we want to do screening tests when we're most likely to find the disease. So that makes sense, except that especially with osteoporosis, we want to prevent the disease, not find the disease.
Right.
Like I can find the disease, that's easy, but we want to prevent the disease. And the fact that we know, as we already talked about, hormones are such strong stimulators of bone growth and bone maintenance. Every woman, if she lives past the age of early 50s, is going to go through menopause, going to lose those hormones. We know that right now about 4% of women are on HRT that are candidates for HRT. So why would we wait 15 years on average before we do the screening study that could tell a woman who's making this decision around the risks of HRT, oh, I already have low bone mass, or what I see all the time is I'm already osteoporotic. Imagine the difference in the conversation of what is the risk benefit of HRT knowing that you have osteoporosis. It's such a different conversation. So just wanted to double click on that because it's such a huge controversy in my mind.
I've seen young women in their late 20s, early 30s who have osteoporosis, and they have no idea. They think that they're healthy. They think that they're doing a lot of things right. And because we get DEXA scans on all our new patients that come in to our human clinics, and because we have it there in the office, but we're catching it in pretty young people who really haven't even thought about their bones. They're just like, it's not even on their radar because of, probably a lot of different reasons for it. But anyway, so I totally agree with you. We should at least be thinking about that as an early test.
Yeah, and we don't. So I think the problem is that we just across the globe, we think of bone health and osteoporosis as an old person disease, right? It is a disease of the elderly. I don't need to think about it, right? I'm a 6 foot tall, 195 pound, amateur athlete kind of guy. I have low bone density. I have since my 20s. I had my first DEXA in my 20s.
Oh my goodness.
So it is, it's a funny story behind that. But It is really common. And I think with all the hormone dysfunction that we see in both men and women, I think we have an epidemic that we just have no idea.
Yep.
So what I want to do, this is my mission, and this is why I go on stages and I speak across the coming up this fall, be across the world, is to change the language around bone health from being a disease of the elderly, that we change it to the idea that we need to use bone health as a biomarker of health span.
Mm.
So what I mean by that is if you're losing bone, something's wrong. We should not be losing bone. We accept that it happens on average because it does, but we
Yeah.
shouldn't be losing bone. I'm showing in my practice that we can grow bone in women and men in their 60s, 70s, and 80s, even without HRT. So we don't have to accept that we have to lose bone. So if you're losing bone, something's wrong. We need to figure out what it is. In order to do that, we have to screen, and we have to screen every adult starting in their probably, mid to late 20s, which with the number of DEXAs in the world is impossible, right? There just aren't enough DEXA screening modalities to do this. And DEXA is not the best tool anyway, because it only tells you about density. So the tool that I think is going to become very popular, and we're working with the companies that can help bring this to market, is an ultrasound device called the REMS. So the Ecolight company, it's out of Italy. They make an ultrasound device. It's the exact same thing you used when you were in practice. It's the same probe, but it has a different algorithm behind it. And you can look at both density and quality of bone. And you can get the T-score for density, but then you can also get a fragility score, which is going to better predict your fracture risk. Now, for young adults, this isn't really a big deal because they shouldn't have osteoporosis. Now, if they do, great, let's get you treated. But what I love about it is that it's going to give you a starting point, and you can measure this over time. So because it breaks down into like a 3x3 grid of different risk strategy, you can say for low risk people, let's just repeat your scan in a couple of years. For moderate risk people, hey, here's the lifestyle things. The community that we have called the Osteo Collective is going to be hopefully baked into this. Let's get you the resources that you need, either free or inexpensively. And then for people that do have osteoporosis, these are the people that are trained in bone health in your country that can do this. So this is a global initiative that we're working on with a couple different companies, and I'm really excited about it.
I love. So is it available currently in the US or is it not even here yet?
Yeah, there are. So, but there's only, it's hard to say. The company says there's 80 devices in the US, which is still would be hard to find, but I only know about 20. So I don't know where the other 60 are, but they're around. You generally are going to have to travel to one unless you're very lucky, and you're going to have to pay cash for it because insurance won't pay for it. But it's 200 to $300 usually, and from my perspective, totally worth it, because we see people that are scared senseless because of their DEXA, but their REMS actually looks pretty good and they have good quality bone.
Mm.
So it's not always that easy, but there are circumstances where this has totally changed somebody's life because they get a different look at what's happening with their bone.
And I would imagine too, for people like, for instance, people who've taken bisphosphonates and they have their DEXA scans look good. It seems like their mineralization is fine, but we know that they're oftentimes building kind of brittle bone. It's almost like
Yeah.
freezing your bones in time, like embalming your bones almost, and they're not doing anything, but over time that's a problem. So I would imagine that a test like that, where you can look at the actual health of the bones and the collagen and all the other kind of support structures in there would be really game changing.
Yeah, that test needs to be, or that study needs to be done to look at that in depth. But I'm with you. I think that what we're going to see in people who are on the anti-resorptive drugs is that their T-score will get better, so it'll go up, but their their quality won't get better,
Yeah.
or it'll get worse over time. And that's my concern with the drugs as well. I think there's a time and a place for the drugs, but they are used as the first line treatment, which I think is totally inappropriate for most people.
Yeah. All right. Let's talk now about the blood test, CTX, NTX, P1NP, all
Yeah.
those tests that you can get through, if your doctor knows about them, you can get these through regular laboratories in general, like LabCorp will at least do the CTX, NTX. I think they do P1NP as well.
Yeah.
They maybe aren't covered by insurance, but talk about those tests and why they can be useful.
Yeah, I'm falling in love with these tests, but I want to give everybody who's here some clinical caveats because they can be misleading if you don't use them correctly. And I just want to answer this question real quick from Jen. Jen asks, can DEXA give a fragility score? There is something called TBS, which stands for trabecular bone score. It's an add-on to a DEXA, and it kind of gives you a fragility score. It's a it's kind of a 3x3 grid, so it's a different risk profile than the REMS will give you. So it's a little bit better than a plain DEXA, but it's not going to be what most DEXAs have, and it's not going to be as good as a REMS. So just to clarify that.
Okay.
So then, yeah, bone turnover markers. So I'm loving these things because imaging doesn't change very quickly. And to say that we're going to do a single intervention and then wait 2 years to retest is just way too long, right? Like, there aren't many supplements that I've taken consistently for 2 years, right? So, like, what intervention am I going to do for 2 years or have that much faith behind it and then retest in 2 years? Now, we see changes in DEXA as early as 6 months, but most people aren't going to see it until 12 months, sometimes not even 18 or 24. So it just takes a very long time. I think REMS will change faster, but we don't know that for sure. It's just clinically, I see people who they get them more than they should because they want to. They'll get them at 3-6 months, and we do start to see changes again around that 6 month mark. But even 6 months is a pretty long time. The bone turnover markers tell us what's happening with the bone metabolism. And I like to shift the entire language around osteoporosis away from the T-score thing, the density thing, and let's just look at it like it's improper bone metabolism. So if we can say, well, you're breaking down too much, you're not building enough, then we know that you have a bone metabolism problem. So let's fix whatever the underlying problem is. And the bone turnover markers can tell us that. So the ones that we use are CTX, and that's the blood marker. You mentioned NTX, that's a urine marker. They're looking at almost the same thing, just different levels of it. The CTX, I think, is more accurate, and we're getting blood anyway, so it's always easier. And then the P1NP, like you mentioned, and the P1NP is also a blood marker. The CTX looks at the bone breakdown. So this is your osteoclast, the cells that are chomping up the bone. And then the P1NP is the osteoblast, the building cell. So those are the ones that are building up the bone. So now you have the seesaw laid out in front of you. What's been challenging is trying to figure out what to do with them clinically, because I learned about these in research studies. So they've been used for years in research studies looking at bone health and the impact of the drugs. So we know, what's happening with certain interventions like the anti-resorptive drugs, but nobody's really ever looked at it like we are to say, are you getting better in the short term? There are some studies that started using a ratio, and this is what we do now too. So the ratio is P1NP over CTX, and this gets confusing because they're in different units. So you have to adjust for units, and this is all like I can give you all this. But P1NP in the units that it comes over CTX, and then you have to divide it by 1,000. So just move the decimal point over. And it looks like usually a 2-digit number over a 0.3-digit number. When you do that, you'll get a number between 100 and 300 usually, and higher is better. So that's the ratio that we're using to say, look, you have enough building to support the breakdown. And if you don't, then what are the tools that we can use to manipulate that? What I love about this is that you could do this on a very regular interval. If you had a lot of money, you could do this on a very regular interval and you could look and see what's happening. But here's the caveat I want to throw out there for everybody, which is make sure when you do these, that you're doing them under the same circumstances every single time. So for cycling women, that's the same day of your cycle. It should be the same time of day. It should be after this. I mean, ideally, like the exact same dinner the night before. There's a lot of variables that will have an impact on the breakdown and the buildup. Not huge, it's not big swings, but because we're getting this ratio, and especially the lower the numbers are, the more sensitive it is to be to these changes. So just make sure you're doing it under the exact same circumstances whenever possible. And then we're getting them at minimum every 6 months. For patients where, if we're taking them off of, say, like Prolia or one of the, the longer term bisphosphonates, and we're watching for that rebound effect, we'll do them potentially every 3 months or every 6 weeks. I know people that do them more often than that. Again, I think you kind of lose the utility at some point, but they're a really cool tool to use in between imaging studies.
And one thing, and thank you for clarifying, I didn't realize that about how sort of variable it was depending on time of day and cycling. One thing I wanted to throw out there is you can, if you don't have a doctor who will order these, there are some labs out there that you can self-order these tests. There are some direct labs out there. I don't have any relationships with them. Maybe you do, but I think it's, I don't know, $250 or so to get those two together. But you can do these, you can get these tests yourself if you want to pay for it and order them yourself.
Yeah, I think it got harder recently. I know Life Extension used to do it. LabCorp used to do it, I think, as a direct to patient, but I don't know that they do anymore. I don't know why, but we have through our community, so for those that are in the US, in the Osteo Collective community. And you just go on my Instagram page, you'll find information about it. But we can order labs through the community that you're ordering yourself, and then you get you get the requisition, and then you get an async report. But it's a way for you to order those as well as some other lab panels that we have on there. It's just we can circumvent the direct-to-consumer pricing because we can do it a heck of a lot cheaper.
That's awesome. Well, we only have a couple of minutes left, so tell me, is there anything that that you're really excited about that's coming into the bone space, or things that you think that people just don't know about that could really change their bone trajectory?
Well, I mean, first of all, the really exciting thing is that what we're showing over and over again is that osteoporosis is both preventable and reversible as long as someone has the ability to do the things that we know are going to be helpful. So those things would be like eating an appropriate diet, doing resistance training, hopefully some impact, and then HRT is a massively powerful tool. If you can do those things, I have not seen a case of osteoporosis not halt and decline and turn around and start to get better. So what I'm here to tell people is that osteoporosis as a disease almost shouldn't exist except in rare circumstances. This should not be a problem as long as we start screening people early and we look for dysfunction, and if somebody's losing bone, we figure out why. This is a disease that should just go away. So that's really exciting. I think what we're going to learn more and more about is the tools that we can use to biohack the system. So I've been in close conversation with companies that make equipment. So one of them I can say, for example, because I just posted about it today, the company PowerPlate making a vibration plate, which some people like kind of reminds them of like the jiggly machines back from the 70s. There's some really interesting data. So I have a device myself, and there's really interesting data that supports using the right kind of device. And that's a company that they're in the forefront of like making sure that the device is doing the right thing. I think using tools like that anybody can stand on, assuming you have access to one, anybody can stand on these. There's a couple of contraindications, but for the most part, anybody can do it. These are things that are going to help drive you in the right direction. So I think the more we learn about what these tools are and how to get them in front of people, the easier people are going to be able to turn the corner on this thing and just see improvement in bone health.
I love that. Well, this has been super educational, and my mom broke her hip a year ago, and so I've been really much more interested. I mean, I've always, and my grandmother broke her. I have I have a long lineage of women breaking their hips. So I need to learn how to not have that happen to me. And so I've been really excited about learning about this stuff. But I love the Tanko message that this is a reversible disease that we can reverse. Like that, I think is so powerful, because I don't think that message is getting out there. I think in general, people think, oh, I've got this thing. It's just, I'm just really fragile now. But that's not the case. So anyway, thank you so much for joining me. For some reason you froze. I hope I didn't freeze. But if you guys don't follow Dr. Douglas Lucas, make sure that you follow him. And he's frozen right now. But thank you so much for everyone who's joined. And if you have other questions, you can enter them